patient. Dr. Verreke is assistant professor at the University Medical Center in Groningen in the Netherlands. He's done countless studies related to anesthetic pharmacology, including pharmacokinetic and pharmacodynamic models, and the use of interaction models to predict responsiveness during anesthesia. He's an integral member of ISAP, and as Conrad mentioned, he has volunteered his time and filled in when others have been unable to help out. He's a great friend and colleague. Dr. Schaefer is a professor of anesthesia at Stanford University. He's the past editor-in-chief of Anesthesia and Analgesia. Perhaps he is most well known in the public eye, at least, for bringing pharmacokinetics to the masses. In fact, I'm proud and embarrassed to say that my parents now know what pharmacokinetics is by watching your testimony in the Conrad Murray trial. So I don't know whether to thank you for that, or it's been some strange dinner table conversations. Nevertheless, importantly, he's a great friend, a great colleague, and a great mentor to all of us. I don't want to take up any more of their time, so it's my pleasure to turn the floors over to Hugo and Steve for this workshop. So thank you, guys.
Thank you. That was a very nice introduction. So there we go. Is this, I share my screen, is this clear for everybody? Can everybody hear me?
I can hear, yes. I can see.
Great, so off we go. I thank you for this nice introduction. It's a bit humbling. So you nicely introduced me. I can't skip this because I'm indeed working in 2 countries, and that has the advantage that you learn to work in several cultures. You would be amazed how different anesthesiology is performed in different countries, and it is really a big experience if you can work in several places, especially if you want to do a scientific approach to anesthesia. Then you really have to struggle with different opinions of colleagues. And so I also am humbled because I co-chair this session with Steve Schaefer, who was an inspiration for me and kind of made me enthusiastic over the abilities of pharmacology to improve my clinical practice. To be honest, it was one of the boring chapters that I needed to study when I had to do a board exam. But afterwards, I realized that this is can be really practical, useful, and improves my skills and can be turned into tools that are to the benefit of my patient. And so I hope with this workshop that we can discuss these tools and that we can transfer a little bit of that enthusiasm that I experienced in the past. I have to declare some conflicts of interest. Some companies were involved in support for the department for our research. However, I do not have direct financial interests in the technology. I just want to mention that I shortly was a part of an advisory board that was involved in developing the Smart Pilot View for Dreger, and that will be mentioned in this lecture. So take that into account. But again, I do not have a direct financial interest, so I will be frank on all the technology that will be discussed. Some technology is not FDA approved, I will also mention that, and I will propose alternative solutions, and especially in the second part of this workshop, Steve Schaefer will show practical tools that can be used at the bedside of the patient to try to achieve the things that I'm going to discuss together with Steve this morning. Learning objectives, we have split up this lecture in 2 parts. At first, I had a nice set of slides that was intended to do an interactive session for 2 hours, but last night Steve had another great idea that we would use the complete second hour for live simulations and interaction. So I had to condense everything into a shorter slide set for that has to be done in 50 minutes. So
Sorry.
the first part will be a bit theoretical. Although I skip all the mathematics, I just want to bring across the concepts of how you should think about effect site concentration. So in order to think in terms of effect site concentration, I will shortly explain the background of that concept and how it can be made as a convenient utility for clinical practice. An effect site concentration is for single drug administration, but I think in clinical practice we combine drugs, so we need to talk about interaction also, and then I will give some advice how information from interaction studies can help to improve our titration skills even more. There will be an ability to ask questions about these topics in the second part, together with the simulations, if that's okay for everybody. So let's give it a go. When I was in training, I learned that the dose for propofol for an induction was 2 milligrams per kilogram. So I titrated in the dose domain. The problem was that I could get a wide range of possible outcomes. And although I aimed for a BIS of 50, which was half maximum effect of the hypnotic drug effect that I wanted to aim for, it's nicely represented by an EEG monitor. So I wanted to go for a BIS of 50. If I gave a certain amount of milligrams, I got this wide range of possible outcomes. Some patients were very sensitive, some were very resistant, and in a distribution, you see a wide range of probable outcomes. So this is not really predictable. You can't hardly call this predictable. Although in the literature, if you market a drug if you bring a drug on the market, you have all this pharmacokinetic and dynamic information available in literature. So it must be possible to turn things around, define which effect you want to obtain, and translate, using all these pharmacokinetic and dynamic models, translate this into the accurate dose for each individual. That's what we want to do. And therefore we need pharmacokinetic information, which tells you something about the relationship between the amount of milligrams given and the plasma concentration. And even if you have a very good description of your plasma concentration, you will see that there's still a time difference between your measured effect and the changes in your effect in your plasma concentration. So you need an additional pharmacodynamic model to cope with this time delay. Okay, in general, which information do you need to be able to do so? You need a pharmacokinetic model. You need a model that describes the amount of the relationship, the mathematical relationship between the numbers of the milligrams per kilogram or the milligrams you give to your patient and the plasma concentration over time. In general, a study to obtain this information gives an amount of drug to a number of patients. These patients have different demographic characteristics. And then at regular intervals, you start taking blood samples. You can have a symposium about what are the correct timings for taking these blood samples, but that would bring us too far for this workshop. Fact is that you collect a data cloud of plasma concentrations that are all linked to the amount of drug that is being given. And then you use these fancy statistics called nonlinear mixed effect modeling to find the best fitting curve on your data. And so we need a simple mathematical solution to describe the time course changes of this curve. And in general, for the majority of the anesthetic drugs, if you do the study right, you can describe this time course using a 3-compartmental model. And in order to understand the 3-compartmental model adequately, you can visualize it as a connected barrel system with 3 barrels of different volumes and connected with tubes of different diameters. You have a tube that brings the drug from the central compartment to the rapid equilibrating compartments, and you have a tube, generally a smaller diameter tube, that brings the drug to the slow equilibrating compartment. And finally, you have this terminal elimination, which is the final destination of the drug outside of the body. So in the beginning, if you give a drug, the model assumes that you give the drug in the central compartment, and it's distributed immediately and homogeneously into that central compartment. Of course, that's a mistake, because in the reality, if you inject a drug in a patient, it will take a couple of minutes before you have some kind of steady state. So this is already a limitation of this model. Still, we use these models because it appears that if you use more complex models, physiological models, models that try to cope with this time delay that you have at the beginning of your infusion, your prediction error of the model is in the same range if you use it in prospective settings compared to the simple three-compartmental model. And just for mathematic simplicity, why using a more complex model if this already is clinically useful? I will show you in a minute when we go to the clinic that it's already an enormous advantage to have this simple model and translate your dose into plasma concentration. Okay, why does this three-compartmental model describe the time course very accurately? Well, in the beginning, you give your drug and you have a high concentration in the central compartment, and it will decay very fast. And that's very logically because it can go three ways towards the fast equilibrating, slow equilibrating, and terminal elimination barrels. And only after a while, you get this equilibration between the fast equilibrating barrel and the slow equilibrating barrel here. And a larger surface has to be cleared, and it can only go two ways. And therefore, the elimination speed is decreasing. And eventually, when the three barrels are in equilibrium, the large surface has to be cleared, and it can only go one way, terminal elimination, and that can take quite a long time. Sorry, that's a bit too fast. Going back. So, luckily for anesthesia, for the anesthetic effects, the drugs that we use are not accumulating in such a degree that we have this condition during maintenance. It's very rare that we obtain maximum equilibration between the three barrels. In general, we are in such a condition where somewhere along this elimination phase, the patient wakes up. And so we are lucky enough that this creates sufficient control in clinical practice for all these behaviors. Of course, if you give high doses for a long duration of time, you will accumulate these compartments in such a degree that you might end up with a delayed recovery because you are very fast depending on this terminal elimination.
Hugo? Sorry, just an interruption. Are the units on the y-axis here realistic in terms of concentration? And could you maybe inform us, if they are, what's the concentration at which hypnosis starts and wake up, occurs during emergence?
This graph is a pure theoretical one. It's
okay.
Just because it's a logarithmic scale here, so it's not really a specific drug here that is plotted.
All right, it's pure kinetics, no dynamics.
No. Actually, can you hear me?
Yeah.
Yeah, Stu, if I can answer, I actually made this graph. The units are percent, so you're just starting out at 100%, which means it works for any dose.
Got it.
Okay.
Great. Okay. Thanks for that clarification.
For this clarification, great. So if you do this for every drug, this is a nice visual representation where you see how different the drugs behave. And take, for example, fentanyl and sufentanil. One of the big differences between these two drugs is the fact that fentanyl, if you give it in a continuous infusion, it accumulates very fast. And this is represented by this large diameter in this connecting tube between the fast equilibrating volume and the central compartment compared to the one in sufentanil. But also if you look at the fast eliminating drugs in anesthesia, you visually see that these models are really very different between drugs. And this is just a very handy, simple way of quantifying the time course of eliminating a drug. Another thing that is very interesting with this slide is if you only want to tell something about the population behavior, you can use fixed values for these volumes and clearances. Because you only want to describe one curve, which is the average behavior of your population. But for clinical practice, that's not sufficient. We want to know whether an obese patient or a patient who is older than the other patient will have a different kinetic behavior. So what is better? We can also translate these, instead of using fixed volumes, we can translate it in, for example, a 3.07 liter per kilo total body weight. Or if you think that, for example, propofol is more accumulating in patients with more fatty tissue, you could consider the fat-free mass and the ideal body weight or other size descriptors that they have a relationship with the volumes or the clearances of one of these parameters. And by adding covariates into these models, you start adapting your model according to demographic variables. And well, one of the good things about nonlinear mixed effect modeling is not that it is fitting the optimal curve on the data, but it provides also some tools to decide whether adding a covariate into your model provides a significant improvement of the fit on your data. And the more a model is able to fit and explain the data accurately by adding certain covariates, the better it, or the higher the probability that it will predict your propofol plasma concentration or your drug plasma concentration in a prospective setting also accurately. So it is just mathematics. It is improving and fine-tuning the basic structural model of the three compartments by adding several demographic variables. Okay, we can talk still for many hours on only that part of the pharmacokinetics, but let's assume that we have the very good pharmacokinetic model. It is able to predict the plasma concentration adjusted according to several covariates, and you describe the time course of your plasma concentration in a certain patient. And simultaneously, you measure a continuous effect like a BIS monitor. Then you see that you still have a problem to control your effect because there's a difference in time course. The peak effect of your plasma concentration will be much earlier than the peak effect in your BIS. And also when the plasma concentration is decaying, the BIS will remain low for some time and only rises when the plasma concentration is already very low. This is called hysteresis and can be represented in another graph also. So if you do an induction, you will see an increase of your plasma concentration, then you will see that the BIS will go lower to a deep low value, and somewhere along the way the patient will lose consciousness at a certain plasma concentration. Then you stop your pump, and according to the pharmacokinetic principles, the drug will be eliminated and the plasma concentration is decreasing. But you will see that the BIS will rise only at very low plasma concentrations. And also return of consciousness will be at a completely lower plasma concentration compared to the induction. This is the hysteresis loop. And if we want to have a control over an effect, we need to cope with that. And that's when the concept of effect site concentration came about. The effect site concentration is not a real concentration. It is not something you can measure. You cannot sample extracellular fluids in the brain structures and then consider that to be the effect site concentration. It is a purely mathematical solution that provide us with a tool to have a better control over the time course of our effect. And so the effect, in theory, the effect site concentration should be able to describe the relationship with the BIS during induction in a typical dose-response relationship with a maximum effect, EC50, and a baseline effect, and a certain slope. And when you induce the patient to high effect site concentrations and stop the pump, the effect site will decay and the dose-response relationship will follow more or less the same time course. That's the basic mathematical idea of the effect site concentration. In theory, the loss and return of consciousness could be occurring at the same effect site concentration in this model. But I have to add a caveat, because there is an issue with neural inertia. The neural brain structures have a tendency to resist change, and there's a lot of debate going on whether this is a pharmacological misspecification problem or not. I'm not going into details there, but for all kinds of reasons, it shouldn't absolutely be true that returning of consciousness and loss of consciousness is at the same effect site concentration. Maybe that would bring us too far. So if there are any questions on that, let's talk about it at another event or later this day. Okay, how do we do this mathematically? We know that all the effects that we get from a drug have a relationship with the plasma concentration. Your hemodynamic effects have a certain time relationship with plasma changes. EEG effects, loss of consciousness, respiratory effects. So there must be a relation with the plasma concentration. By adding a single elimination constant called the infamous KE0, which is expressed as a fraction per minute, we can evoke an effect site concentration that has a certain time delay versus the changes of the plasma concentration. And so the KE0, for example, for propofol in the Schneider model is expressed as 0.456 per minute. So that means if during 1 minute the plasma concentration goes from 0 to 4, in the same minute the effect site concentration will go to 2. So it goes a bit later than the increase of plasma concentration. It will reach a peak effect that is close linked or much closer linked to the peak effect of the BIS. In ideal models, it should be the same. And then during decay, also the effect site concentration will be eliminated a bit slower than the plasma concentration. So by doing so, we should be able to cope to obtain this situation. That's the theory. So again, it's a mathematical construct. It's not something you can confirm by measuring brain concentrations. There have been experiments in animal studies where they try to do that, and then you get this range of variability. I think it's a false expectation. You have to validate the effect site concentration by looking at the time difference between plasma concentration and effect. Is that clear?
So, Hugo, it's clear as I think as far as you explained it. But if the KE0 is actually only half a minute or 2 per minute, it shouldn't take that long. I mean, the equilibration between the central compartment and the effect site shouldn't take that long. In other words, why can't, for instance, that lower left curve be established by just pseudo equilibrium experiments? Or is it just really just impossible in animals to reach pseudo equilibrium with propofol?
The question is, the question is if it's necessary. I think from a pure scientific point of view, it might be interesting to have a really detailed understanding of this pattern. But I personally think that this is a tool that is meant for clinical applicability, and it needs to provide a clinical improvement in predictability. And I will show you how that works in the current setting. But I agree, there have been a lot of debates on what is the correct K0 for a certain effect. It is something you can debate on whether, sorry, what I would like to say, this is a factor that is co-varying with the pharmacokinetics. It's depending on the accuracy of the pharmacokinetics also. That's an important caveat. The K0 is also depending on the accuracy of your pharmacokinetic model, and there's always an inaccuracy here. It might be that patients that are, for example, deviating from the average expectations in the pharmacokinetics have a tendency to have a slower equilibration in the brain or a faster equilibration. So we don't know this. These are all covariates. They all are linked together. So you have to look at the model as a complete unity when you want to apply it in clinical practice. Steve, I see you want to add some comments.
Yeah, Stu, as I understand your question, or perhaps I don't understand your question. If you,
Okay.
Well, you mentioned an equilibration experiment. The equilibration experiment would help you establish what is the steady state concentration versus response relationship.
Right.
And that is exactly correct. That if you bring somebody to steady state, and that has been done, the whole point of introducing a KE0 in the model is to get that same information, because the concentrations at the effect site that are predicted when you have the KE0 are, in theory, the steady state concentrations that you would get if you did the steady state experiment. So it's allowing you to see the concentration response relationship in the absence of a steady state relationship. Now, the test that's usually done for that is typically you have a hysteresis curve. So you give a big blast of propofol, plasma concentrations are sky high, but the patient's wide awake. Why? Because it takes a minute or two.
Right.
And then as the propofol drops down, what you see is that the plasma concentrations of propofol are quite low, but the patient's still asleep. Why? Because the brain has to catch up with the plasma. So you have an equilibration delay on both sides. When you adjust with this first order rate constant, the question you ask is, after you do this adjustment, do you have the exact same concentration response curve on the way up and on the way down? And if you do have the same concentration response curve, that's pretty strong evidence that you've captured the equilibration delay.
Okay. So I get that. So the model simply assumes no hysteresis, and you basically find the model that collapses the most.
The model without KE0 is a model without hysteresis.
Yeah.
And when
Okay.
you introduce KE0, you are actually modeling the hysteresis.
The hysteresis in both
Right.
directions. Yeah.
Right. But as Hugo said, and the two things about it, first off, the question is a single first order equilibration delay adequate? And you just look at the data. And for most drugs, it is. If you have things like the notion of inertia, then it won't be adequate, and you'll see it because there's no value of a KE0 that would actually give you the same concentration response curve on the way up and on the way down.
Got it.
Yes. Another thing I need to mention is that we are working in a setting often for this kind of constructions where we induce a patient and then wake him up again without doing surgery or giving a noxious stimulus instead. And you have to realize, and I will show you when we go to clinical practice with these concepts, that of course surgery has an amazing influence on the relationship between your effect site concentration and the clinical effect. So, and that's something you need to start titrating. But the concept of effect site concentration helps you to control the steady state conditions once you are in a range of effect where you want to be. But now I'm jumping ahead a little bit. Okay? Now, next step. Let's continue here. Okay? This is just a slide where I'm really showing that for some drugs like dexmedetomidine, you can model multiple effects and have, and they are all driven by the same change in plasma concentration, but you can see the relationship between the effect site concentration and different effects. For example, when you leave a patient in a dexmedetomidine sedation at ease, you have a relaxed BIS number, and you can correlate this BIS number with certain effect site concentrations, which also are compatible with the sedation degree. So the probability that you reach sedation score between 2 and 3, this is the modified observer assessment and alertness scale. So this is a patient that is in between responding, non-responding to shake and shout. It's a very good sedative level. This will be corresponding with if this is evoked by dexmedetomidine with a BIS of 50 on average. The blood pressure with the same effect site concentration will be close to baseline, although you have to watch for a phase of hypotension when you get there. And also the heart rate will decrease a little bit, but not in dangerous conditions. So using an effect site concept to model multiple effects of the same drug really provides a lot of information on how you can reach a safe and effective sedative level in the majority of your population. So this is just an example of how complex you can make the relationship between your plasma concentration and effect. Now, the ultimate goal, how should you think about using an effect site concentration, which is a prediction of the average behavior in a population? How can you use this in your individual patient? Well, you aim for a BIS of 50. So you know from the population studies that you need to target the EC50 for that, the effective concentration, 50%. So the effective effect site concentration to reach half maximum effect. And for BIS, that is around a BIS of 50. And so then you set this EC50 as a target, and reverse mathematics are used to use all the pharmacokinetic dynamic model parameters, including the relevant covariate information, and decide, so the computer decides which amount of milligrams should be given over time in the different patients to allow them to be in a comparable effect range as desired. And that's the basic idea. You turn things around, you set your effect site concentration, and the dose is determined by the computer. How effective is this? Well, it will be disappointing because you will see still a lot of variability. There still will be patients that are more sensitive than others on that same effect site concentration. But if you look at it in a distribution and your model is any good, and you have coped with the accurate covariates, then the distribution will look more like this. And you will indeed reach a BIS of 50 on average in your population. But if you succeed to have a model that leads to the majority of your patients being between a BIS of 40 and 60, you have increased the predictability of your anesthetic effect. You have decreased the risk of outlier behavior, not excluded. There still will be outliers, but a minimal amount of your population, you need to adjust your effect site concentration a little bit. And that's just because apparently for that individual, the estimation of the model is inaccurate and you have to adjust a little bit. But if you succeed to have the majority in this range, you have done a good job in clinical practice. And this is confirmed by the studies that we've done. If you administer propofol over time in 15 different patients, you can plot the effect site concentration of propofol as estimated by the Schneider model versus the BIS value, and you determine the individual dose-response relationships. And so if you do that, and you target a single effect site concentration of 5 micrograms per milliliter, indeed, you will have an average BIS of 50. This is the EC50 of propofol without opioids, without premedication. that's good. The model is good. It predicts the population average. But for these two individuals, it's really bad because this one is very resistant and has a much higher BIS than what you would expect. And this one is disappointingly low and is much more sensitive. But look at the majority of this population. I think 70 to 80% of this population is with a range between 37 and 62. I think this is a very accurate model to optimize your clinical practice and to increase the predictability of your clinical effect just by targeting one single effect site concentration. And of course, you have to adapt for this one. You will have to decrease your target, and this one you will have to increase your target. What are the reasons that these are more resistant or more sensitive? I don't know. There are many reasons possible, but the fact that we have evidence that relates a BIS number with an effective concentration, with an effect site concentration, it allows us to stratify our patients after induction to be sensitive or resistant to the drug effect. And this will adjust your decision making for the remainder of your anesthesia. I think this is a key message of what we are going to explain today. And this is just for a single drug. We can do the same for multiple drugs with the same kind of reasoning. The only problem is that for analgesic effect, we lack adequate monitoring systems. That's the limitation of using multiple drugs. A second advantage, apart from predicting that apart from predicting that the majority of your population is within a certain clinical effect range, also the time course will be controlled much better. Because if you use a TCI pump and you set a certain propofol effect site concentration, the pump will give a very complex administration of drugs. It will give a bolus of propofol in such a way that it overshoots the plasma concentration to a higher level than what you want to have in your effect site. And then the pump will stop, go to zero for an amount of time that is just enough to let the drug decay towards the desired target. And the moment that these two are in equilibrium is the time to peak effect. And then the pump will restart with administering a continuous infusion to maintain that effect steady. That's how an effect site controlled pump delivers the drug. How will your BIS respond? Individual 1. I have a BIS of 55. Look at the time course of the BIS. The second one, I don't know what the BIS will be. It's a vulnerable one. He has a BIS of 27, but look at the time course. The other one is a resistant patient. Look at the time course. I know that if I repeat this experiment over and over, the majority of my population will be between 40 and 60, and only a limited number needs an adaptation. But the time course, we have a steady state within a couple of minutes. If you do this with a bolus and a continuous infusion, even then, effect site concentration simulations will show you that on average, you have an overshoot, and the continuous infusion will maintain a steady state only minutes later than using an effect site controlled TCI. And indeed, look at your effect. You always will see this overshoot or tendency to overshoot in the BIS. And of course, there still are very vulnerable and more resistant patients, but you see that effect site allows you to control the time course better. And by avoiding this kind of overshoot, I'm convinced this will diminish the risk for hypotension, respiratory problems during sedation, and so on and so on. Although the models are tweaked to control an EEG effect, they also tend to have the other effects in a steady state quite fast. And this is proven by studies. This is an effect site controlled administration of propofol. This is a plasma controlled administration. So even with a plasma controlled administration that takes into account different covariates, you will see that the effect is insufficiently controlled. The standard deviation of the BIS result remains very high during the time after administration, whereas with the effect site, it's much smaller. And also, there are some outliers here. In the loss of consciousness, look how unpredictable the timing of loss of consciousness is. There's one individual who only loses consciousness at 10 minutes. And the prediction of loss of consciousness is much more accurate with an effect site control TCI. You might see that in the beginning, there is a little bit of variability, and that's probably due to model misspecifications. Effect site control TCI also needs a couple of minutes to reach a steady condition. For volatiles, the same is true. You should think in terms of effect site concentration when you use a volatile agent, especially when you change your concentrations. Because during induction, you have reached an end-tidal concentration of 1.3 Mach very fast. But in this, this is a screenshot of the maquette ventilator, and they plot the McBrain on their ventilators, which is a kind of an effect site concentration of the volatile. And you see that it takes about 9 to 10 minutes before the brain equilibration has reached the same effect as your end-tidal. And also during recovery, your Mach awake is reached very fast when you stop volatiles. But the McBrain takes many more minutes before it reaches the Mach awake. And every clinician knows that you have to stay below the Mach awake for a couple of minutes before the patient wakes up. So this effect site concentration surrogate, the McBrain, will probably have a closer relationship with the clinical effect than the end-tidal. And this is also shown on this screenshot of the Smart Pilot View, which is a simulation software package, where also the end-tidal is decreasing very fast, but the effect modeling is done with the effect site concentration, and they clearly include the time delay seen with volatiles also. Okay, there is evidence that if you use TCI in sedation, you have less respiratory events, both for propofol as well for a combination of propofol and remifentanil, less problems for scope introduction, and a spontaneously breathing patient that is not deviating towards hypoventilation. Okay. I will now go to clinical practice. I start a case and I explain how my decision-making is influenced by my effect site, by thinking in terms of effect site. And I will take a simple case, no problem at all. A lean adult, 20 years old, female, normal weight, normal length, and it's for, she is scheduled for ovarian kyst resection and laparoscopy. I will use effect site control TCIs in this model because I can. I know it's not FDA approved, and that has something to do with how to validate a concept like effect site concentration. That is a bit of an issue in the process for the FDA. And I'm not going too much into detail there. So this is my practical setup. I need one pump for every drug that I want to control in TCI. So I need 2 pumps, one for propofol, one for remifentanil. I strongly advise to read guidelines for the safe practice of total intravenous anesthesia. This includes many good advice. I think it's a medical error if you do not use an anti-backflow valve when you use TIVA anesthesia. Why? If there's any reason for an obstruction on your infusion line, and then the drug will be infused in the infusion bag, and you have first the calculations of your model will be wrong, and you risk to give a massive bolus when you open your perfusion bag. I think it's a medical error if you do not use this. And secondly, you know that the models are a bit inaccurate in the first couple of minutes. You can diminish that problem by keeping the distance between your infusion lines and the perfusion or the connection to the patient as short as possible. That's a second advice. But there are many more tips in this guideline publication. And then you need to select the correct model. Also, I'm not going to be very detailed on this because you can fill a complete convention on which model is the most accurate. I selected the Minto model and the Schneider model because both are compatible with lean adults and elderly. it's not a good model for obese and not for children, but in this case, it's accurate model. The second reason why I use it is because these were the models used for the majority of the interaction models. And I'm going to talk about that in a minute. And finally, I think the discussion of which model is best suited for which patient will be diminished a lot when the broad purpose pharmacokinetic dynamic models for propofol and remifentanil will be commercially available. These are models that have provided pharmacokinetic dynamic models from a large database, including children, elderly, obese patients, and so on. There's also a remifentanil model from the Utah group. I didn't mention it here. My apologies for that, because yeah, it's certainly, there's a dynamic going on in the academic world that we are going to have better models in the future, diminishing the problem of model selection. I select effect site control TCI. If you desire, you could use plasma control TCI, but remember that you have to target a higher target in the beginning and decrease the target over time if you want to maintain your effect sites as steady as possible without overshoot. And again, that requires human intervention, and every human intervention can be a cause of error. So I prefer effect site control TCI. And then the main question, what are the optimal combinations? What is the optimal combination of remifentanil and propofol? This is I think 80% of my cases I start with, for general anesthesia, I start with 4 micrograms per milliliter in the Schneider model and 4 nanograms per milliliter in the Minto model for my remifentanil propofol combination. Why? Interaction models. We have interaction models for the very practical clinical outcome in anesthesia. And they use, for example, propofol and remifentanil. The idea of interaction models is you target towards an effect site concentration of your drug A and drug B, and you have a look what the combined effect is doing. So you collect a lot of information. For example, you look at the number of non-responders and the number of responders for patients who are either tolerant or non-tolerant to laryngoscopy. And then you can plot the optimal isobol on that data set, which is the best fitting curve. The isobol is the line that connects all the combinations of drug A and B that have the same effect. So an interaction model is a 3-dimensional curve where if you give a single drug, you see the typical dose-response relationship of each drug. And if you start combining, you can consider it as a new drug with new characteristics and also a typical dose-response relationship. So if you do this for all the combinations, you have this complex 3-dimensional graph. And the isobol can be found by doing a transaction and looking from the upside down to the screen. Okay, this is an interaction model. We have that for anesthesia drugs. And for example, for my case now, I look at the Honeyford model and I see if I combine 4-4, this is the isobol for BIS. Here, this is the isobol for BIS 40 and BIS 60. If you add remifentanil to a propofol anesthesia, your BIS will decrease a little bit in an additive way. So that's the straight line. And so with my 4-4, I may expect in the population an average BIS of 45, and the majority of my population will be with a BIS between 40 and 60. That's what the models predict. There's also another interesting feature that is the probability to tolerate laryngoscopy. This is the isobol to tolerate 90% of my population will tolerate laryngoscopy here. And I'm very close to the 90% line. So I have a hypnotic effect that is within target, and I have only in 1 out of 10 patients, if I do a laryngoscopy and there's a little bit of hemodynamic response, I stop the laryngoscopy, I take back mask ventilation, and I increase my remifentanil because this is the individual that needs more. But the majority of my population is okay with one setting. That's the force of interaction models. I want to point out an important issue about limitations of interaction models. The number of data points to extract the isobol in the extremes is very low. The majority of data is collected in the middle. So the model is less trustworthy in the extremes than in the middle. That's something to remember for later. If you look at the volatile agents, very interesting combination. You do the same rimifentanil combination and you titrate towards the same BIS, a BIS around 50. Majority of the population will be between 40 and 60. Then you need to have an effect site concentration of 1.6% end-tidal. And look at the probability that the patient will tolerate laryngoscopy. This point is much further away from the isobol of the tolerance of laryngoscopy. So if you do a balanced anesthesia with volatiles, the probability of a movement is lower with the same BIS as with TIVA. It's a very interesting observation. Also for this model, we have much more data points, you see, which increases the trustworthiness of the model. We also have interaction models on respiratory function. And so with this 4-4 combination, you see that this patient will need respiratory support. It's a general anesthesia. So, and for sedation, this is a very interesting model because you can really find safe ranges for having anesthesia and a sedation. Look how steep the dose-response relationships are. A slight increase in your rimifentanil can cause tremendous effect on your hypoventilation risk. Very interesting to combine effect site with interaction models. Okay, one step further, I start my rimifentanil in my case. It targets toward 4, and I ask the patient, tell me when you feel a bit dizzy. My impression, this is not scientifically proven, it's a clinical impression, is when the estimated effect site concentration is between 1.5 and 2.5, and the patient feels dizzy, that's a normal sensitivity. Then I can expect that for the remainder of my anesthesia, this patient will behave normal to the opioids, and probably I don't have to do crazy things for the postoperative analgesia. This is a normal responsiveness. If the patient already feels dizzy at 0.5, maybe that's a very sensitive patient. And if he reaches 4 and still doesn't feel anything, that's the patient that needs more rimifentanil. So it's just the same reasoning over and over again that I try to stratify my patients in relation to what I expect from the population. I can also use the pump to optimize the time to peak effect. I know for sufentanil, I need to wait a considerably longer time than for fentanyl. So if I use a TCI pump, I can wait for just enough time that all the peak effects of my propofol, sufentanil are at the time of intubation when it's needed the most. And of course, for alfentanil and rimifentanil, this time to peak effect is much shorter. That can be simulated by effect site also. Patient is a bit dizzy, I start my propofol, and the patient loses consciousness at a target of 2.7, and this is not a trick slide, this was the actual case. The target was 46, the BIS was 46. So I always like it when a prediction becomes reality. My impression is that although the models are wrong, the fact that you can stratify a subset of your patients as being sensitive or resistant, it really helps to improve your titration. Okay, maintenance is difficult. I can't advise for maintenance. There are so much factors that need to be taken into account. Sometimes you have to wait for your surgeon. The incision, the type of surgery, the fluctuation of the noxious stimulus. As an anesthetist, you still have to anticipate that and increase your rimifentanil in advance of the stimulus. If you do not adjust your targets, you will see unexpected responses because the condition of the patient is changing due to surgery. This study has looked in clinical practice in a lot of cases with TIVA anesthesia, including opioids, and they saw that in the majority of cases, this is the range of targets for maintenance of anesthesia with the Schneider model. What I liked in this study is that only 10% of the residual variation could be attributed to weight and age, which tells you something about the weight of the covariates. The weight and age are already compensated to a large extent in the PK models. Okay, I have to hurry up a little. So during maintenance, you're free, you're the anesthetist. You have to decide where you are going to serve on the spectrum of combinations. You are free to do whatever you want and just serve the wave. But I think it's more logical to stay close to this range than titrate towards this range. Because the higher you titrate away from this population average expectation, the higher the fraction will be of patients that are overdosed during maintenance. They receive too much anesthetic potency, and you will pay the price during recovery, because during maintenance, the accumulation is going on of your drugs, and you need to wake a patient up, and what can help is a calculation of the context-sensitive half-time. Every drug has a tendency to accumulate, and I already shown that fentanyl has a severe tendency to accumulate if you give it in continuous infusion. If you compare this to sufentanil, sufentanil is even better for the first 10 hours of anesthesia than alfentanil. For me, this is the preferred TCI drug if I don't want to use remifentanil, because of the optimal accumulation of the context-sensitive half-time. Why is the context-sensitive half-time? Look at the 3-compartment models. If you give a drug for 1 hour, the volume that is filled up in these compartments is rather low. And to reach the half concentration of the initial, you can go still 3 ways with your drug and fill up the other containers, and you have your elimination. So you have a short time to reach your target. Whereas if you give your drug for 6 hours, you have to clear a large volume and you are depending on your terminal elimination. So you need much more time. The models predict the context-sensitive half-time. And you can set it on your pump, but in the pumps, you only can set the plasma concentration, and that's a disadvantage. You should be able to set the effect site concentration because there's a time delay. But you can calculate it. And now we are at the alternatives, which we are thoroughly going to discuss in the second part. If you have no availability of effect site control TCI, you can use simulation software. There are commercial software systems like the Smart Pilot View from Dreger and also Navigator from GE, although I have to admit that I don't know what the current commercial condition is of that technology. I didn't hear a lot of it. I don't see it at the booth of GE. So I'm not certain. I'm not certain how it is. I know that GE is available, that Dreger is available. I also see that there's a renewed interest. There were some publications with new models that are meant to be used in clinical practice as a simulation and use simulation to optimize your drug titration. And of course, the advantage of this is that some of the data is registered automatically. Pumps are connected to this system, whereas if you use pure simulation software, you can make an error. You are depending on the quality of your input of data for your estimations of the effect site and interactions. But there's a lot of available to simulate and help you out in clinical practice. I think we approach a short break now. Maybe I should keep this for after the break. What do you think, guys? This was already a lot of information. Maybe we should keep this for the second part.
Why don't we take a 5-minute break, and yes. We will, so everybody stand up and stretch. I'd say take a deep breath in, but I don't have that option right now. And we will, I'll start up here on my computer clock at 6:35. So that's 4 minutes from now for everybody else. And by the way, Hugo.
Yes.
Absolutely fabulous.
Well done.
Great job, Hugo.
Thank you.
Yeah, thanks. Okay, we'll see you guys all back at 6:35.
Thank you for the attention. Mute.
Je comprends rien du tout. Dans la série Les Grands Agités, nous avons un institut Schaeffer qui série sur fond de paysages lunaires.
All right, I think it's time to get going again. A couple quick things. Can you hear me?
Pourquoi j'ai Google puis c'est pas là, moi? Hugo?
Yes, no problem.
Allô?
Yes, I can hear you.
Excellent. All right.
Allô?
Hello, hello,
Coucou?
hello. Don't know who's saying hello, but nice to hear
Ah bon,
you.
d'accord. Mais
So,
je comprends.
my suggestion is
Je
that.
suis connecté depuis le début, moi. Mais bon, je dois dire que les diapos de Hugo sur
Okay, so I recognize that voice. Frederic. Hello, Frederic. Can you mute your microphone? All right.
I muted.
Excellent. So welcome, everybody. I wanted to start off by saying that was a great summary from Hugo. And as I'm sure you folks know, Groningen is now the center of clinical pharmacology and anesthesia worldwide. I mean, it's the one place where they're continuing to move the field forward. They are continuing to do research for the phase 1 studies, phase 2 studies on the new drugs that are coming into anesthesia. And Hugo's part of the team put together by Michelle Streets and colleagues. And as you see, when I'm talking about the papers that are moving the field forward, they're coming from Hugo and his colleagues in Groningen. So Hugo, I just want to thank you for that and acknowledge that you guys are the leaders in this field today, and it's wonderful to see how you are continuing to progress everything.
All credits to Michel Stress, who is really who has the vision and the endurance to make it happen.
He does indeed, and I agree with that completely. But it takes a team to do this. So, what I'm going to talk about is a simulation program, and I'm going to use a simulation program to review a lot of the concepts that you just presented. And you are welcome, as I do this, to call the program up, because this is something that's online and available to everybody. I can tell you that at Stanford, in the very first lecture that I give on pharmacokinetics, which is in the first week of residency, I show our residents how to use this, and they use this quite regularly in the operating room just to help plan their anesthetics, to help understand what's going on in their patients. And to, it's one thing to see the graphs, but to engage with it interactively is really what we want people to start doing here. This is supposed to be an interactive workshop. So I'm going to demonstrate. Please interrupt me with questions, send me chats. Stu, you're hosting this, correct?
No.
I'm hosting it, Steve.
You're hosting, okay. Jane, if chats come up, could you just keep an eye on the chat box? Because
Sure.
I can't both talk and watch the chat box at the same time. All right, so the program is called StanPump R. And it's called, the StanPump is a program that I wrote years ago. I actually started on that. I just realized I started working on StanPump 34 years ago. So, and it became a program for target controlled drug delivery. Jonathan, I don't know what's quite happening with your iPad, but I hope that hand was yours and not someone else's. StanPump is a program that was used, sorry, thanks, Jonathan. It's a program that was used to make target controlled drug delivery available. Initially, it was intended for our use at Stanford. For our studies, it was then in the commercial domain. And the basic code from StanPump, the pharmacokinetic engine, is the same as the engine that was then adopted into RugLoop, and I believe into virtually all of the commercial TCI devices that are available. However, it's not available in the United States, and the code at this point in time is almost unusable because it's a DOS program written in C. And what I realized in years is that there was no general purpose simulation program to explain this concepts. So I created something called StanPump R. It's the StanPump program, but it's written in the R programming language. And to be honest, it uses virtually none of the original StanPump code. It was redone from scratch. But the idea is, at this point in time, to run simulations that, particularly for the US, can bring people close to the idea of what is TCI. The key thing is, if you just go to Google and search for StanPump R, you can find it right here. And this is it, stanpumpr.io. So stanpumpr.io will load up the program for you. And I have to tell you, as I'm starting a live demonstration of software, I have to let you know that perhaps inadvisedly, but we just finished a major recoding of the program to enhance what's called reactivity about 3 weeks ago. And one or two things are not working quite right. So if it blows up on me, I do apologize. We should have done the update a couple of weeks after this meeting instead of like 2 weeks before the meeting. But this idea of demonstrating something that doesn't work and blows up on you is something that I've sort of adopted, that it's best practices from Microsoft and the way they handle their Windows upgrades. So it starts off with a warning message. This was actually suggested by Michel Street, saying I really needed to do this. It's derived from the original StanPump program developed at Stanford University, performs pharmacokinetic simulations based on mathematical models published in the peer-reviewed literature. So it's intended to help clinicians, it's intended to teach, it's only advisory, and how these models are applied to individual patients is a matter of clinical judgment by the healthcare provider. So that's just a disclosure to say that this is a simulation program. All right. So let me take you through the basic screen here and how the program is set up to allow you to do simulations. You have your three major covariates here: age, weight, and there's a little pop-up that says enter weight and select kilograms per pound, as if that wasn't completely obvious, and height. These can be entered in kilos or pounds, and for age, you can enter it in years or in months. For most of the drugs that we deal with, if you can just get those three things right, you've actually, oh, by the way, and also the sex. If you can get those things correct as far as the pharmacokinetic influence of age and weight and sex, you have accomplished a lot of what is possible to accomplish. I spent years trying to identify all kinds of other covariates in some of the publications that were talked about. And frankly, just getting the influence of weight alone correct and the influence of age alone correct, just getting those correct is often as good as you can do. Nonetheless, the program is set up to have different pharmacokinetics in pregnancy, and I have not implemented that yet. You're welcome to click it, but nothing changes. For a couple drugs, it's set up to handle CYP2D6, rapid, typical, and slow, and it's set up to handle renal function, normal, impaired, and ESRD. But keep in mind, the program only knows what's published in the peer-reviewed literature. There is no a priori assumption here. So if there is not a model for propofol in end-stage renal disease, then there's not a model in stand pump for it. People used to, when I first started talking about kinetics and TCI, they'd say, well, you know, obviously make an adjustment for people with cirrhosis. I'm like, well, actually, it's not that obvious, because if nobody's published the math, I'm not just going to do it like, you know, take a guess. Somebody has to have published the math to use these. So this is where you enter the patient covariates. Down here is where you enter your drug doses, and this is a dose table, and it starts off with the default for a general TIVA anesthetic. The program does not yet have inhaled pharmacokinetics. I've had talks with Jim Phillips about adding inhaled pharmacokinetics. I should mention that so what you do, there's a choice of drugs. The choice of drugs is pretty extensive. You have propofol, remifentanil, fentanyl, alfentanil, sufentanil, morphine, pethidine, which I have to explain to my US colleagues what that is, hydromorphone, methadone, ketamine, dexmedetomidine, midazolam, etomidate, rocuronium, naloxone, oxytocin, and oxycodone. So it has a large number of the drugs that you're likely to be using intravenously in anesthesia. If there are other drugs that people are interested in, the program is set up to be very easy to add additional drugs. You then go and enter your times. There are two ways of entering the times. It's currently, it starts off by setting a time an hour before the time on your browser. So there's actually a clock right here starting at 5:30 because it's 6:30 a.m. here. I can also run times relative to time 0. And the intention of this is so that if you say time 0, then everything readjusts and you just have your standard way that we talk about things in kinetics. But when residents are using this in the operating room, and they say, okay, I'm in the operating room, and you know, I'm starting here at 6 a.m. All right, well then they can say, okay, at 6:10 I did this. There are two ways of entering your drug doses. You can either enter them on the table here, or you can just click on the graph. So at 6:10, let's say I'm starting my anesthetic, and I'm going to give, oh, I don't know, let's give 100 milligrams of propofol. Let's give 120. Now I have a choice. Am I going to do milligrams per kilogram, milligrams per kilogram per minute, or milligrams per kilogram per hour? So there it is. As soon as you do that, you get a simulation that comes up. So for starters, I'm just going to take these other drugs out of here, and we're just going to talk about propofol and examine some of the pharmacokinetic concepts that Hugo just reviewed. So if you double click on something, one of the options that comes up when you double click is to delete the drug. And we're just going to go and look at propofol. And every time I do this, I'm holding my breath to hope the damn thing doesn't crash. As I said, I should have done the revision 2 weeks in hence rather than now. All right, so here's propofol. So this is the concentration in the effect site for propofol. That is the default, to show the effect site concentration. Why? It's the only concentration that matters. Unless you're doing forensics where you want to see the concentration at which somebody died, the plasma is not the site of drug effect. Now you can put in the site of drug effect if you want to. Currently it's set to blank. So I'll add it as a dotted line. So now here's the plasma concentration as a dotted line. And you can see the net effect is it goes to this very high number, it comes down crazy fast, and it doesn't really tell us anything useful. So my default is not to show the plasma concentration at all, but if for some reason you're interested in showing the plasma concentration, you can do it. You can also normalize. Here I have no normalization turned on, but I can normalize to the peak effect site concentration, which looks like this. And now everything's here is given in terms of percent. All right, and you can see here, the plasma concentration goes to basically 4-fold higher than the effect site concentration. But Stu, as we were talking about in answer to your question earlier, when you said, what is the axis? I like to use percent of peak, because then I have something which is actually independent of dose because of the linear pharmacokinetics. Or I can normalize to peak plasma concentration, in which case my axis rescales this way. But I'm going to turn the plasma concentration off because I frankly don't think it's interesting, and so I'm just going to set that to a blank. Now, we have here but I'm still normalized. Let me take the normalization off. Good. So now we're back to looking at the effect site concentrations. You'll see there is a bar here. And where this bar comes from is the concentrations that have been recommended in the literature for the drug, typically for general anesthesia. Because if you just tell someone off the top, okay, here's propofol. Look at what you get from propofol. You know, you start out here, you go up to effect site level of 5, you come down quickly. What do you do with that information? You know, that's if you don't have a number to put up against that. So you can show, that's down here under show typical. And I can take it off and you can just look at this, but I find it hard to look at the numbers without something to reference it to. I can put the midpoint of what's considered to be your target, which is here. And I just have it as a little wide bar so you can know it's not like a pharmacokinetic prediction, but I actually like to see the range. And the range is typically where I can find it in the literature, the 95% confidence bound.
So Steve,
yes, sir.
does the range change when you change the patient's age in this model?
It can. Currently it's not set to do that because I haven't put in the math to do that. But absolutely, yeah. Now the other thing you can do, by the way, is if you come down here to edit drugs, this actually allows, and this is really intended for people who are using it, but it allows editing of all sorts of things here. I have the ability to do something similar to actually allow you to edit, because you can edit anything in real time. To do that, the whole point of this, though, is that I really don't want users to be making pharmacokinetic decisions. When the literature is complex, the literature is confusing, and the goal here is to have a program that has the latest information. So along those lines, what are the models? Well, the pharmacokinetic model that I'm using here, I don't know, here it is this model right here. This is the model from Groningen, and it's Doug Elleveld's sort of Uber model, where he took all the data from the Open TCI initiative, took additional data, and somewhat to the distress of Thomas Schneider, because his model is often used, but this has Thomas Schneider's data in it. Those data are all of the data that Thomas used in creating his model when he was at Stanford. All of those data are part of this model. And I think this is the future of pharmacokinetics. If people will share their data constantly, these models will grow, and then let the computer make the choice. Having a clinician make the choice is just a setup for problems. Our goal is not to make our goal is to make things safe, and having clinicians make choices like this is not in the interest of patient safety, in my view. So it has the Elleveld model for propofol, for remifentanil, by the way. We have the Elleveld model as well. So it's no longer the Minto model in Stand-Pump R, it's the Elleveld model, which again is designed to span, and here's Hugo, again, it's the team, mostly but not entirely from Groningen, although the Netherlands are well represented here. And the idea is, let's have the best models we can, and this is a way to make those models available. So back to the program. So now we've started our anesthetic here. now let's, okay, what this tells me is that, boy, just to see, I did this at 6:10. By about 6:15, I need to do something else because the patient's levels are dropping. And if I don't want this patient to be awake, I may have an issue here. So I think what I'll do here is I'll start an infusion. And so I'm going to run it, and I don't know, how about 100 mics per kilo per minute? That's kind of a pretty standard thing for us. So I'm starting this at 100 mics per kilo per minute. And you can see here, by the way, you can do it either way. You can enter your doses here, or you can just simply click on the graph. All right, well, you could immediately see a problem with that approach. 100 mics per kilo may sound great, but I started it too late. And my levels are coming down, and that's not going to be enough to keep me where I want to be. So I'm going to have to do something else here. Maybe what I should do is start my infusion a little bit earlier. So if I click on this, I can edit prior doses. And what I'm going to do is I'm going to take this right here. I'm going to change the time. I'm going to make this 6:10 and sort of start at the same time as I get my bolus. Just let's see what happens here. All right, so that's a little bit better. I don't dip down quite as low, but I'm still running this a little bit lower than I should be. So if I'm just going to be running propofol here, maybe what I want to do is take this up, and we'll take it instead to 120 at the very beginning. All right, so we're improving. I might be just a touch lower than I want to be, but keep in mind this is propofol only. And maybe we need to add another drug to this. So at this point in time, what I'm going to do is I'm now going to add some fentanyl. We're going to start our anesthetic with fentanyl as well. So I can just type in here, fentanyl. There it is. And what I'm going to do is I'll do it at 605. Hopefully that'll come up to 605. No, that comes to 605. That's probably not what I want. That's a long time from now. Let's go 0605. And that should do it. Very good. Okay, so now we have the fentanyl added here. And I don't know, should we start with 100 mics of fentanyl? What does that sound like? So now we can see coming in here the fentanyl effect site concentrations as well. And it's coming up, it's peaking a couple minutes after it. So what we have now is our fentanyl is getting us there. We have the propofol. And then if I want to look at the interaction between them, I can click here. And this brings in the interaction. I have to say that the interaction models are not quite as robust as I would like them to be. But basically, what it's telling me down here is the probability of response to noxious stimulation based upon the work done by Thomas Bouillon when he was at Stanford. There's a propofol opioid interaction model. It's actually remifentanil, but if you adjust for the potency of the drug, then we're getting it based upon the fentanyl effect site concentrations normalized to potency. And what it tells me is that I'm actually okay, because I have throughout here, because of the small amount of fentanyl, I have a pretty good interaction here, at least for the next hour. Well, how about a couple hours from now? How's this going to look? Well, a couple hours from now, it says that my fentanyl is dropping, but my propofol is accumulating. So you can see the propofol accumulation here. And because of the propofol accumulation, it says that my interaction probability is still quite low. I personally think this part of the program, even though it's based upon a pretty extensive analysis that we did in 2004, I think that needs some additional work and update. And so part of this is, the ISAP community. This is the group that helps do this work. And welcome for thoughts on how to do that. So the next thing to point out is that I can do this thing called time until. So the context-sensitive halftime was designed to get around this issue that there's no standard pharmacokinetic parameter that tells you how fast the drug goes away when you stop giving it. People used to think that half-lives did that, but we saw 30 years ago that half-lives utterly fail to tell you anything useful, and you needed to do simulations and understand the context-sensitive halftime. Well, I think that's true when you're talking in generalities and you don't really know what the person plans on doing with the information. But here we're talking about a 50-year-old, 60 kilogram, 66 centimeter woman who has received these drugs. And the context sensitive half-time isn't what I want to know. I want to know how fast the drug is going to go away when I stop giving it. And in fact, that's what the target controlled infusion devices do. There's a little thing which says time. I mean, I assume they do it. Stand-Pump does that. And Hugo, these devices do that too, right?
Yes, it's the decrement time. It's called the decrement concentration.
Exactly. So that's exactly it. It's the decrement time. I'm so glad to know that was the term you used. It's the decrement time, and it shows up in real time as you're running it. Well, if I ask for time until, it's the same concept. It is the decrement time down to a specific number. And the specific number is this thing, which I show here now on the opposite axis, called emergence. And let me get rid of the interaction here, because that's actually a little bit, I mean, emergence is when the probability of response is 1. It's the way that works. But for these, it's easier to show. So this gray area here, you need to be in this gray area at the bottom to emerge. What is emerge? Well, emerge when you're looking at propofol is when you're responsive, and emerge when you're, and by the way, we think levels of about 1 are where people wake up from propofol in the effect site. And emerge for fentanyl is when you're breathing spontaneously, and that's about 0.63. That's a number that's been around for literally decades, established years ago by Gorski, I think his name is. But anyway, these are the levels at which you are breathing spontaneously and you have an analgesic concentration. So this number right here for fentanyl, the 0.63, you're going to have, you're above your medium effective analgesic concentration at that number. And what it tells me is this. For propofol, initially, I'm about 4 minutes away, because you see, here is the scale. But as I continue to infuse the drug, you can see the accumulation right here, until by the end of it, at not the, well, the end of the simulation here, which is at 9 a.m., it takes 8 minutes for the propofol to adequately go away. So you can see you can watch yourself digging yourself into a hole. Now let's say instead of doing this, I'm just going to leave it at this infusion rate and I'm going to run it for 10 hours. Well, if I do this and I run this for 10 hours, you know, I'm really getting in trouble with propofol. Why? I'm just in my therapeutic range, but I've pumped so much drug into the periphery that it's going to take me a couple hours to get rid of it. And those of anybody who's tried running propofol at 120 mics per kilo per minute for 10 hours has seen this, you know, which is why I don't do that, because this is going to get me in trouble. So this is not a good strategy. Let's say, however, that instead of that, let's say I want to go just along the bottom edge here. Well, right here, in a 10-hour anesthetic, I can look at this and say, gee, at 10 o'clock, really what I should do is let's cut my infusion rate from where it is. Let's take it and cut it down to, oh, I don't know, let's cut it down to 80. Now let's see what that does. Well, oh, I just gave a bolus. That's not what I wanted to do. I want to give 80 mics per kilo per minute. So we're switching this to 80 mics per kilo per minute. And now we're not at 3 hours. Now we're just running this at 92 minutes. But that still might be a little bit too much. So perhaps at this point right here, I might want to take it down to 50. So I'm going to come in here and take this down to 50.
So just to be clear, Steve, your target zones that are plotted are again not altered by the interaction of adding another drug infusion.
That is correct.
Okay, so the response probability is probably a better guide under these conditions.
Correct. All right. So I'm going to go back to here. And I want to go back now and do something a little bit different, which let me go for a more typical TIVA approach. By the way, when you saw the reload thing, it didn't like something I did there. That should not have happened. Let's see. I may need to restart my browser. Okay. That's really unfortunate. That's actually something happening on the Shiny website here. So what I will do is let me do two things. Let me close my browser and reopen it. And Chrome should work fine. The other thing that happened, by the way, I'm not trying to make excuses or anything, but R just changed to version 4.0 a month ago, and we're having versioning issues here. All right, so that opened fine, so that's much better. Okay, good. So what you might do for a typical induction of anesthesia is maybe what we'll do is at time 0 here, we'll start with again 150 propofol, say 120 propofol, and for fentanyl, I'll go ahead and start with 100 of fentanyl. And the Remy, let's just go with 0.1. And the rocuronium, I don't know, let's go with 60 milligrams. Okay. So what you see here now is the Remy is coming up, and even at 0.1, we're above where we need to be for the Remy, which is not a problem because it's Remy. So it's going to be very, very forgiving. And now what I'm going to do is I'm going to add my propofol infusion right about here. And when I go to add my propofol infusion, we'll start it at 100 mics per kilo per minute. That looks good. There it is. Okay, so now you can see the propofol is being maintained. Propofol is a bit low, Remy is a bit high, but that's the beauty of this technique, because if I go ahead and look at the interaction, what we'll see in the interaction is that there's no probability response because of the interaction between propofol and remifentanil. So if you happen to think this looks like a nice anesthetic that you'd like to try out, you can email it to yourself. And if you put in your email address here and click on go, what it's going to do is it's going to take this anesthetic that I've just outlined here. It takes a second to assemble the email, but here's the plot that it just sent to me. So now if I go to my email here, which is always dangerous to do because you'll immediately see my political views. not that I think they'll surprise anybody. Let's see here. Oh, I sent it up here. I sent it to Stanford. By the way, I don't know if anybody else knows this, but whenever I'm here, and here's the simulation. If you've noticed this, whenever you're sharing your screen with Zoom, your system slows down immensely. So I just got this email from Stan Pump R. Here's the simulation you requested. It tells me who I'm simulating. If I click on this, I can reload the simulation itself that just ran. So that's the URL to my simulation. But this right here is a PowerPoint file. As I say, screen sharing really slows things down. Also, I'm running multiple other monitors here while I'm doing this, just so I can see things. So let me bring this down to this screen. Where to go? It's interesting. It's hiding behind Zoom. My apologies. One sec. All right. So I'm going to pull this into my screen that it's being shared. And here's the simulation that I just ran. And this is a this is actually a Windows object. So you can take this and put it into your presentations. You know, you can say this isn't really propofol, this is really some other drug, because it's just a Windows meta file. The other thing that is there is a spreadsheet. And if I open the spreadsheet, and again, I apologize, but it's going to open on some other screen, so I'm going to have to drag it into my shared window. Let's see. All right, 1 second. So here's my spreadsheet. Notice I got it from the web, which it doesn't really care for. Here's my patient covariate, so I know, you know, what I put in here. Here's the dose table. Here's what's actually being simulated. Here's the simulation results for all the drugs. So this is actually the drug, the time. It's done the way it's handled in R for the graphs. So it tells me that this right here is the concentration at this time of rocuronium in the effect site. And then this is the results that are used for plotting, if you actually want to plot these out yourself, where you basically have things set up as XY variables. Also, for each drug that's present, I have what are the kinetics that are being used. So this is the volumes and the clearances, the micro rate constants. Stand pump internally doesn't use those. Stand pump uses these exponents and coefficients because that is mathematically much faster. So these are the internal numbers that are, but everything's, you know, it's all related. They're all derived from the others. And you'll see, by the way, also that there's things about PO, intramuscular, intranasal, bioavailability. It's for every drug, the default is to have the ability, obviously for propofol is not used, but for alternatives to IV drug delivery, and we'll get to that in just a moment. So, and by the way, that's fentanyl, here's propofol, here's remifentanil, and here's rocuronium. So it's a quick source of the basic pharmacokinetics, adjusted based upon what's what's been published for a patient with these covariates. All right, now back to the program. So I can send myself a slide, and this gives you an idea of the basic functionality of the program. If you want to do things just to say, you can say, you know, for tomorrow's case in OR 28. And, you know, I can go ahead and add a legend in here for it. Boy, the web update is glacial. And a couple other things now about it. So we've talked about your plotting options here. We've talked about being able to send slides to yourself. We've talked about the dose table. The dose table can be arbitrarily large. There is no limit on the size. And you actually can go up to showing about, I think you can show 10 drugs at one time. The next thing I want to mention is the concept of MEAC, M-E-A-C. So if I put in MEAC here, that gives me an additional scale, which takes all of my opioids and normalizes the opioids to the minimum effective analgesic concentration. It's kind of like the MAC concept is for, I apologize, that's what I want to pull up. I wanted to be able to see everybody, and I don't know where that screen went. I'll just leave it. Oh, here it is. Good. Okay, so the MEAC concept is it takes all the opioids, divides it by the opioid potency for analgesia, so you have them all on the same scale. And with this, you can see here the contribution of, that's really strange because I didn't do anything. It just disconnected, so there's an instability, not in the program side, there's an instability on the Shiny app side, which is a little disconcerting. And will it come up okay, or will it immediately crash here? Yeah, I spent a couple hours last night with the fellow who's writing the JavaScript. I do all the R coding, but somebody did the JavaScript part of this, and got it up and running. But I just have to. I think there's some. It's interacting with the cache in a weird way. So my apologies, but no problem. I'll just pull it right up again. Fortunately, I can do if I do this, it will
Steve, can I just make some impressions that I have on
Yes.
this demonstration? I can really appreciate that. First of all, there are many more drugs in these simulation software package than, for example, in the commercial devices like Smart Pilot View and GE. I think there is also much more capacity to have a look at the subtle differences between opioids. You mentioned that the opioids are calculated based on analgesic potency, which is not the case in Smart Pilot View, where the EEG effect is used to determine equipotency.
Mm-hmm.
So I see that this is more a reflection of what is available in literature. And I think it's a great educational tool, and I think for clinical practice, it can be very practical that you have this dose table to try to mimic your case that you simulated in advance. What I'm struggling about is the problem is that the dynamic of surgery can create certain disruptions of the relationship between these estimated concentrations and the corresponding effects. And that's why I prefer to strive for a combination of using effect site concentration to control the time course of your drug effect, but add an individual measure that allows you to stratify the individual response to the estimations. And that's something that I struggle with the other simulation apps like Tiva Trainer. It's quite labor intensive to add all the data in the simulation while you are doing anesthesia, and sometimes you do not prioritize to it because you have a sudden change in the condition. It's a challenge to do this online at the bedside of your patient. Or do you have other experiences with that?
I have, but almost invariably. So a couple of things. One is once it's not doing what it's doing right this second. So I'm now, by the way, going to the test site because I'm thinking that perhaps what's going on here is that the Shiny server itself, shinyapps.io, is interrupting things. Because in the last case, I just sat here watching it and I did absolutely nothing, which means the program shouldn't be doing anything. And all of a sudden it stopped. So I'm now on the test site here. But as I mentioned, we introduced some instability just recently, plus the change in the fundamental version of R. So currently, I use this in the R pretty commonly, but it's always sort of after the fact. And it's sort of like saying, why is this patient taking so long to wake up? Okay, let's put in what you did and let's figure it out. And it's interesting how much insight you get from this. Or I'll have a thing like where somebody calls me and says, oh my God, I gave sufentanil, but I forgot it was sufentanil. And I started my case with 100 mics of sufentanil instead of fentanyl. What's going to happen? And I can pull this up and say, well, actually, that's a lot of drug, but you're probably going to be okay here if it goes about 3 hours. By 4 hours, I don't recommend you give a lot of additional opioid, but you're probably going to be all right here. And in fact, if I add my time until, because the axis, it gets pretty hard to see there. But there is something very strange going on with the Shiny server, or maybe it's going on with Chrome here. And let me pull it up. But anyway, so I use this as an after the fact simulator. I can also try this. Yeah. Go ahead, Euro.
Well, can I otherwise just for a couple of minutes shift the screen share and show how you also can use the simulations more in a bedside setting?
Sure.
Wait a minute. I try. Does everybody see the screen or not? No. Sorry. I think I. Sorry. Going back to the Zoom platform. We still have to practice with this, huh?
Yeah.
Share. Okay. Can everybody see the screen now? Yeah. Okay. I guess it is. So what I would like to show is that, of course, within limitations, the Smart Pilot View has not all the opioids available, has not has a certain amount of limitations, but as a bedside simulator, it has a couple of advantages. A lot of the data is registered automatically. Every drug that is being given by the pump can be read out by the system without you having to enter any information. And every simulation software, you have to enter all the drugs yourself, which is quite labor intensive. And only the manual boluses that you give, you need to enter them manually into the system. And as I show you here, it calculates the underlying effect site concentrations online for remifentanil and propofol in this case. And on the plot you see in the yellow color, you see where your effect site concentration of opioids and propofol relates. So this orange dot is where you are now. The black dot is where you will be in 10 minutes, and the triangle is where you will be in 15 minutes. And you also have an estimation of the time to reach the TOS, the tolerance of shake and shout, in 50% of the events when you stop now. So also I think the power of such a system is that it makes it less labor intensive to get all the information that you get from the simulations. Personally, I'm not such a good computer geek, and it kind of runs out of control when I start to do it in a simultaneous fashion with my case, and this is kind of an answer. Like I guess the GE system will also do that, but it's just that you really see the pattern. Like you see also the difference with the bolus and a continuous infusion and a TCI titration. You see with TCI, I get in a steady state immediately. Like here, I titrated to 4/4, my typical combination, and indeed I'm slightly above the tolerance 90 isobol, and the patient responded to my laryngoscopy. And so I increased my remifentanil and propofol a little bit, and then after the intubation, I decreased my concentration, and this visualization allows me to stay in the same range as the isobol. So I think this is a more visual educational reference that helps you having an idea where you are. I have to admit that there are limitations to the predictability of these models, and the user should be aware of that. You still are, as an anesthetist, personally responsible to anticipate to certain changes in the conditions. But having this information visually ready, available, I think this is a clinical way of helping you out with the issues that you try to solve with the simulation also. I really think that, like, for example, the transition from a sevoflurane setting, which indicates your MAC in the interaction domain, you can switch as if you use propofol. You switch to the propofol domain, and we have then the y-axis now becomes a propofol expression. Now, although we use sevoflurane, you can translate your TIFA condition with your volatile condition and translate it as a tolerance of laryngoscopy response. And there is, to my opinion, still need for prospective validation, whether these predictions are sufficiently accurate and safe to use as a guide. I personally prefer to explain to the trainees that it's a reference of what you can normally expect in a population with the demographic characteristics that you have defined in the system. It's not a prediction of the individual response, but I tend to see that in general, I can decrease my amount of drug that I give to to a large fraction of my population without having much problems during anesthesia. Here you see, you get also some estimations where you will be if you change your volatile target in the next couple of minutes. So it helps you to prepare your recovery. And I think this is, of course, limited by a couple of disadvantages. Here you see that I add some opioids. I give a bolus, a manual bolus of opioid, and you see on the screen here that's a prediction of where your target will be in a couple of minutes. So it's very interactive and it's on the spot. If you make an error and you want to delete it, you can clearly delete one of these boluses, and then you have again the new situation. So if you make an error and you have put your bolus of opioid a bit in a wrong time frame, you can easily adjust it. I think it's very flexible, although I realize that there are limitations, and the limitations are mainly related to not all drugs are included. People like to use a combination of dexmedetomidine and clonidine. And then, of course, you could wonder whether these predictions are still accurate. But I compare it with the MAC. We use the MAC as a reference also. And although the MAC is only valid when you use volatiles alone, where if you combine it with opioids, you also have to extrapolate. So the same is true with the information that you get in such a system. And another important limit is the demographic limits, because they use the same models, the TCI models that have limited ranges of applicability. And so these are disadvantages. But the good thing is that you do not need TCI pumps. It has multiple opioids that can be translated in remifentanil equivalents, although it's based on EEG potency. And this is also interesting, this new depth of anesthesia monitor based on the probability of tolerating laryngoscopy. I think that's a kind of a MAC extended. So the MAC only applies to volatiles, but the NSRI is a measure of the total potency when you use volatiles, propofol, and a mixture of opioids.
Hugo, may I make a few comments?
Yes.
Okay. First of all, I do not agree that you should not use, or you can use it without TCI, because it's difficult to titrate from a curve in a short time, you know. Whereas when you've got a TCI pump running, you may change the concentration much quicker. And another point is that one way to use this smart pilot view, when you know where your patient is in the range of curves of the MAC and 50 and 90, you can sort of know the sensitivity of your patient. And then you know that if you move on the same isoball, you will have equipotent couples. And this is a way to titrate your patient. And in clinical practice, I found that this way of using the smart pilot view was perhaps one of the more clinically relevant way.
I totally agree, and that fits very well with the first hour in the session, because I use these tools also to stratify my patient, my individual patient, in relation to what I expect in the population. That's a repetitive decision-making step, where if I see a patient that has sufficient anesthesia in this range of drug effect, then I'm worried. I think this is a warning for me that I shouldn't leave the OR. This is a patient that has such a sensitivity for the combination of drugs that he appears to be adequately anesthetized. But you know that compared to the average behavior in a population with comparable demographic characteristics, you have to be aware that this patient is at the edge of what you can what you can reach in avoiding overdosing. So it warns you for the sensitivity of your patient, or the other way around. Some patients you really need to titrate in this region. And for example, a patient who has a chronic alcoholic use and has a kind of a resistance for a lot of, or a chronic opioid user, for example, it's amazing how high you should titrate in some of them. And still they wake up quite easily. That's just because this is the outlier patient that does not fit according to the model, but it still provides you a reference to stratify all your patients according to the evidence that is available in the literature. Still, I'm a bit prudent because we lack prospective validation. We still need to understand whether it's safe to titrate here and here. You have to realize that a small shift in your propofol creates a large difference in prediction of tolerance of laryngoscopy in these ranges. And we don't have a monitor for analgesia effects. I like to use it with, for the hypnotic effect, it's quite easy with linking the effect site concentration with a BIS response, but for the movement effects and for the tolerance of a noxious stimulus, you have to still be very careful and interpret these informations wisely. We still need validation, prospective validation for such an approach in clinical practice.
Hugo, can you hear me?
Yes.
Before we end the session, it looks like we have a question, one more question from the audience. That's from Dr. Mandel. Are you still there? Do you still have a question? Is Jeff still out there with a question? Okay. I think it's time to wrap up the session.
Sorry.
Oh, are you getting me now?
Yeah, I can hear you now.
Okay. You can hear me, Jane?
Yes, I think everyone can hear you, so that's good.
Oh, okay. All right, great. Okay. So Steve, I took a So Steve, I took a quick look at your R code, and oh boy, I'm echoing.
Just turn your mic down a little bit.
You're actually not using your headphones is what's going on. It won't echo if you use your headphones. You're
okay.
not using them.
All right. Well, let me take the headphones off. Does that make any difference?
Yeah.
No. Okay, maybe I should just type the question in. But Steve, so I took a look at your R code, and the question I have about it is, it looks like you're, rather than using micro rate constants, you're just doing everything as exponential solutions. Is that correct?
That's correct. That's what. Yes.
Yeah.
Well, it's not entirely correct. There is an option to advance the model using micro rate constants for truly nonlinear models. And that has to be used in a couple settings. But for the most part, I'm staying in the world of rate constants. For the dexmedetomidine model that adjusts for cardiopulmonary bypass, that has to be done with micro rate constants, and it runs much more slowly. But let me also point out that Hugo, smart pilots used to deliver drugs, where obviously, if you have a system that's delivering the drugs, the point I was hoping to communicate is that the point of stand pump R is to understand pharmacology and to understand pharmacokinetics. We may eventually try to integrate it with EPIC, but that's like way in the future, and that's really not my goal. My goal is you have a program you can set up, before you do your anesthetic, and people are just welcome to play with it. But you can run any kinds of things. We're using it in clinical studies where we're giving oral and intravenous hydromorphone, and we're trying to understand how oral and intravenous hydromorphone interact. Or you can look at giving a pre-op dose of oral codeine and how that's going to work. And this is a simulation program for teaching. It's not a program that is attached to a pump.
Yeah, I agree. I think this is an important difference. It depends on what you want to do with the models. Personally, I would not use the Smart Pilot View as it is constructed now for research. I mean, for titrating my drugs towards a certain effect, there is still insufficient prospective validation for that. I prefer using the TCI pumps directly. what I still think that there's an educational value to it, and
Of
the
course.
difference with if I use the PKPD tools or I use the TIVA trainer, this is a tool that I use for educational purposes because I always struggle with the labor intensity if you want to simulate things while you are doing anesthesia. And indeed, the purpose of Smart Pilot View is providing all this complex information in an easy to interpret interface.
Why are they are?
So, guys, we're gonna end the session here. We're
Okay.
gonna do a 5-minute ISAP business meeting for the ISAP board members. For the rest of you, please consider this your 5-minute break before our first session.
Great. Thank you all
Steve
for
and
your
Hugo,
attention.
excellent talk. Thank you both so much.
Thanks, Hugo and Steve. This is Konrad Meissner again speaking. We've had an audience of more than 50 subjects throughout, and just for the example of my institution, we have a full conference room with residents next door. So I think this was a pretty successful thing. So thanks again for